Okay, I think we're going to get started, guys. I'll just make a quick intro to myself. My name is Jim Min. I'm a cardiologist with a focus on imaging and prevention. I spent the early part of my career in the CCU for the most part, like for 7 or 8 years. Then I had a patient come in. He was like 31. He was a security guard at the Museum of Natural History in New York and came with a massive ST elevation, myocardial infarction, and cardiogenic shock, and thought, I think I'm on the wrong side of this care continuum. So switched over to prevention and learned a lot through imaging. I think in contrast to sort of what I think many vendors would do is like show every single feature of their product. Like what we want to do is just spend the next hour talking about how we're going to take care of patients and how we're going to actually use this data in real life. So we've got like an amazing faculty here. We've got 3 past presidents of the FSCCT. We've got probably the best preventive cardiologist that I know, and probably the best clinical trialist that I know. So it's going to be a great session, and we're going to talk about a new product that we got FDA approved about 3 months ago, I think, called Cleerly Compare. And I'm going to just spend 2 minutes, and then I'm going to sit down and let these guys do what they do. But when we first started the company, it was 8 years ago now. It's hard to believe that it's been that long, but we set out on the first day and said, like, we have a mission, and our mission is to try to create a world without heart attacks. And so, how are we going to do that? Well, we felt that the treatments were there and were arising and emerging, that the identification was lacking, that we weren't finding the people in the right way. And so basically what we did was we looked back at what we were taught and realized that a lot of what we were taught was wrong. So when I was a medicine resident, I trained at the University of Chicago, and we were taught to do all those things on the left, right? And over the last 3 decades, they've been largely supplanted by the things that you see on the right. What is the commonality between a mammogram, a colonoscopy, a lung CT scan, even a pap smear? Is that they use some form of imaging to directly visualize disease. And that has been the secret, like, to the success of the most successful preventive care paradigms in medicine. So when I contrast that with the way that I was taught as a cardiology fellow, we obviously don't do that, right? Like, we rely on risk factors, which fail the majority. We wait for people to have symptoms, which fails in the majority. And then we do all these stress tests, which fails in the majority. And so we just need a change because we're not doing what we can do to identify the patients who are at risk. And so what we wanted to do was to adopt that same similar paradigm where we said we're going to use advanced imaging, we're going to do it safely, we're going to directly visualize disease, we're going to do it at the personalized and individualized level. And so we as a field of cardiovascular medicine, I think, are the most evidence-based in medicine. But what we are stuck with are group-level comparisons rather than personalized medicine or precision heart care. And so what we thought we could do was to try to personalize medicine. And we had a clinic at Cornell and New York Presbyterian where I worked, where we did these 5 steps sort of manually, and it worked. We created in this tiny little microcosm of a prevention practice in New York City with 5 cardiologists over 7 years. We created a world where none of the patients had heart attacks. So we felt like that was the way to do it. And it was identification of disease through coronary CT angiography, really educating our clinician colleagues, empowering our patients through direct visualization of the disease so that they understood the seriousness of the condition, treating N of 1 in a personalized fashion, and then doing quantitative tracking. And so this Cleerly Compare device that was just recently FDA approved is like sort of the culmination of how we can do quantitative plaque tracking over time. So without further ado, let me introduce our next speaker. I'll just say that these speakers will speak their own mind. They're going to tell you whatever they think is right. We've not coached them to say anything. And so everything they say, like, just know that it's from them. It's not from us. But I do want to introduce our next speaker, who is Dr. Maros Ferencik. So Dr. Ferencik, as you guys know, is the immediate past. Are you still the president of the? He's still the president. He's got 23 more hours in his presidency of SCCT. He's a board-certified cardiologist at the Knight Cardiovascular Institute at Oregon Health Sciences University, specializes in coronary disease, cardiac imaging, cardio-oncology, and he's an MD PhD, completed advanced fellowship training at Mass General and Harvard Medical School, I think under our Chief Medical Officer, Dr. Udo Hoffman, and is board-certified in CT, nuclear, echo. He's a master of the SCCT, the MSCCT designation, and is recognized for his expertise in using advanced imaging to guide care for patients with complex heart disease conditions, particularly those undergoing cancer treatment. treatment. So without further ado, I'm going to introduce you to Dr. Ferencik.
Thank you, Jim. Thank you for the opportunity to speak. Also, thank you Cleerly for supporting the society on the behalf of the board and ECN members for all that you do in terms of education and support of the field of cardiovascular CT. These are my disclosures. So this is really the right time. We are celebrating on 20 years. And on the left-hand side, we have what has changed in the last 20 years. We have fundamentally changed how we understand coronary artery disease, coronary atherosclerosis. We went from the invasive coronary angiography, where 20 years when we started society, it was all about the stenosis, can you detect, what is sensitivity, specificity. Now with the improved quality of our CT scans, we can see the plaques, and we moved to the next stage of actually quantifying the plaque, thank you to the analysis, such the one that we discussed today. Over the course of the last 20 years also, we fundamentally change how we understand and evaluate patients that come and we say, well, you have suspected coronary disease, you have symptoms, or you have risks that make us believe that you may have coronary artery disease. And for many years before, you know, if you came and you had chest pain, for instance, and you went to the stress lab, you know, he said like, oh, you have ischemia, you need to go to the cath lab, so no, we know whether or not you have stenosis. And these are relatively small groups of patients as compared to this huge group of people out there that have coronary atherosclerosis, which is the most powerful predictor of future of cardiovascular events. Now we moved from the stage where, and we had these slides this morning, and Ricardo had it, where we were like, we can detect plaque, we can see it, we can even compare it to intravascular ultrasound. We moved from that stage to the next stage where we actually can understand what the plaques are composed of. And we, over the last decade, learned that actually the plaque composition, what the plaques look like, is the strongest predictor of future cardiovascular events. And it's indeed non-calcified plaque, especially the low-density non-calcified plaque, that is the strongest predictors of major cardiovascular events. We also understand on the other side of the spectrum, and that's very important to understand that we have plaques that actually are more stable and are associated with a lower risk. We now know that the very dense calcified or 1K plaques are associated with lower risk of future cardiovascular events. So now if we know how the plaques look, what is sort of our goal, what the plaques, when we have it, should like, we can now see whether over time we can transform plaques, whether we can give patient therapies that it will lead us to changing from, in quotes, bad plaques to, I wouldn't call them good plaques, but maybe better plaques over time. And this goes along with our histological understanding of coronary atherosclerosis. This is one, you have the good books, you have these old, you know, what Peter Libby and all those vascular biologists wrote, and we, for decades, we were sort of focusing on the people with this sort of advanced disease, they rupture, they have stenosis, and we sort of ignored all the people on the left-hand side. But those are the people that actually we can change their fate. We can change their fate and make sure that they don't come into the ICU when they're 31, or 50 for that matter, or at 70. So when we measure the plaques, we now, because of the spatial resolution and the fidelity of the analysis, go beyond just looking at the calcified or non-calcified plaque. We actually can characterize the density of plaques and their characteristics based on Hounsfield density measurements and other characteristics due to AI/ML-based analyses. And instead of having this binary definition that you have plaque or not, or maybe definition of a few categories, you have calcified, non-calcified, partially calcified plaque, we have a continuum where the risk of events changes from the continuum, where you're the highest risk when you have these necrotic, lipid-rich plaques, and the lowest density and the lowest risk when you have these high plaques, high 1,000 K plaques. So now that provides for the follow-up another opportunity. You don't have to go from non-calcified plaque to calcified. You don't need to just grow new plaques. You can actually understand how the plaques that you have, how they change their composition, and with the change of compositions, how their prediction of future cardiovascular risks changes. Again, opening a new era where we model or follow the therapeutics based on the characteristics of the plaques. Now, of course, this is now anchored in a huge body of data that we have in the literature showing that we can detect the stenosis. And actually, when we detect stenosis with AI-based QCT, it's as good or maybe even better than invasive coronary angiography as compared to gold standard of invasive FFR or true hemodynamic significance. We have IVUS data showing when you measure the amount of plaque, the volumes, the volume of subcomponents, it's similar or corresponding to intravascular ultrasound. We have the data from near-infrared spectroscopy IVUS, where we actually can characterize the type of plaque. We have plaques that are lipid-rich, which the NIRS can detect, and we know that this actually is associated with the presence of plaques with low attenuation, Hounsfield index. And we have OCT data, OCT, which shows the highest spatial resolution of all the intravascular techniques with 10 micron resolution. And again, we can see the plaques that are on OCT, thick cap fibroateromas, basically what you see in histology. And we can see that with quantitative assessment of plaques, we can correlate these on CT. And finally, something that we're not going to in extent discuss today, but we can evaluate hemodynamic significance of stenosis. And we know from now multiple trials that Cleerly based ischemia algorithm actually correlates very well with invasive FFR. With that, I would like to thank you, and I would like to invite Ricardo Cury and Jim. Thank you.
Awesome. Thanks so much, Maros. Let me introduce our next speaker, who I think everybody knows. So Ricardo Cury, he's the past president of the SCCT, he's the chairman and the CEO of Radiology Associates of South Florida. He's the section chief of cardiac imaging at Miami Cardiac and Vascular Institute and Baptist Health of South Florida. He's also chair and professor of radiology at the FIU College of Medicine. He is the former director of cardiac MRI at the Mass General Hospital. He's authored over 250 publications and currently the CMO for data strategy at Radiology Partners. So, Dr. Cury, thank you.
Thank you, Jim. Thank you so much. A pleasure to be here. And here I just would like to share our early experience. So we have had, trials, used many softwares in the past, participated in multi-center trials with different clinical tools. And recently we have implemented basically AI plaque quantification and AI lesion-specific lesion ischemia in clinical practice. So we have been using this in our large clinical practice. And to start, I would say one of the things that we have been most impressed is with the accuracy of the delineation of the lumen and the plaque boundaries and the plaque characterization and morphology. So really having robust tools that we can quantify and simplify and augment our readings has already made an impact in the past few months. I would have to say that we do our, when we are looking at before AI tools, really trying to do a blinded read, and then we looked at the AI result, and when we are looking at intermediate lesions in a diagonal or obtuse marginal branch, and if you see the validation of the tool, even for those smaller branches to be accurate, is reassuring. But here for this technology, basically the software, and we are able to manipulate using the Cleerly labs, the quantification of the lumen in cross-sectional, in a curved straight MPR, the plaque evaluation, a 3D view that you can select the vessel that you want, and the regular multiplanar reformat. So it provides an advanced platform for interacting with the data and accurately quantifying stenosis and plaque. Also, there are tools that more and more we are getting familiar, which are web-based tools that in a one image, it color codes the areas that there might be, different degrees of stenosis, red being greater than 70%, yellow 50 to 70%, and light blue mild disease, but also the total plaque quantification, in this case 417 millimeter cubic, and then the breakdown of non-calcified, calcified plaque, what is the percentage atheroma value, how many segments you have a severe stenosis, and you are able to interact and also select your CAD-RADS, and we'll give you a nice summary towards the end. So it does provide in-depth plaque and stenosis measurements that we use to validate our clinical read and augment and also like minor discordant findings. We also improve our accuracy. So it provides a full text report that we use, particularly the summary of the plaque quantification that we are able to add to our regular cardiac imaging coronary CTA report. And for the provider, for the general provider, and also there are like detailed patient customized reports. And the general provider, in one graph bar of each vessel, we're easily able to delineate, which vessel and what is the percentage stenosis and the category. So with that, going to the next step is we work with different preventive cardiologists in the South Florida area, particularly Arthur Agostone. He has a large database of his patients that actually he does track, and we provide the imaging for him, atherosclerosis and changes in management and medical treatment. And this is one example of a patient that had a baseline CTA. You can see that the yellow is the non-calcified plaque, is just highlighted as non-calcified plaque, and the blue is the calcified plaque. So that's the baseline CT angio. 3 years follow-up, you can see that most of the yellow plaque is transformed in blue, which is the calcified plaque. So the non-calcified plaque transformed in calcified plaque. This patient was treated with PCSK9 inhibitor. And when we looked at the quantitative data for plaque volume, you can see that the plaque volume remained the same, so 260 to 255 millimeter cubic, but it did not progress in a 3-year period, which is important, so relatively stable. But most importantly, the non-calcified plaque went down from 140 millimeter cubic to 57, so there was a 60% regression or transformation of non-calcified plaque in calcified plaque. So if you look at the calcified plaque, actually the calcified plaque went up. So this is a great example of a plaque that got stable, so halting new disease progression, and also the transformation and converting non-calcified plaque in calcified plaque, and provides a really, we're not flying blindly, a tool for the patient of reassurance, but also for the preventive cardiologist that can ensure that his clinical treatment is working. Another example, also tracking disease progression, baseline CT angio using the disease tracking and the 18-month follow-up, we can see actually regression just in the visual images. You see more yellow non-calcified plaque, and the red is the low attenuation plaque. And in the follow-up, you can see shrinking of the plaque, even in a visual manner, and also the significantly decrease of the low attenuation spots. When we looked at the quantitative data, this patient was also taking a PCSK9 inhibitor, 55-year-old man, but you see the non-calcified plaque actually going down, the total plaque volume going down about 30% each. The low density plaque, a significant reduction in the low density plaque, and a slightly increase in calcified plaque. So is another example that the treatment is working, and we are not only plaque regression, but also not progressing over time. A different example of a patient that actually was not adherent to treatment. So you have a baseline CTA with basically very minimal disease. And the 6 years follow-up, now you have a proximal LAD lesion with both a non-calcified plaque, low Hounsfield unit, and spotty calcification. So you can see in this patient where the medical treatment was not working, progression of plaque from 64 to 195 millimeter cubic. The non-calcified plaque also increase, and the low-density plaque increase. And unfortunately, this scenario, we see that all the time. Just this past week, I had a colleague of mine, he had a calcium score 10 years ago, 40. So he was placed in atorvastatin 20 milligrams, and he came back now in 2025, 10 years later. And his calcium score this week was 1,500. So he went from 40 to 1,500 in 10 years, and he was still taking 20 milligrams atorvastatin. So we lost a decade where we could have imaged that patient early on. We could have intensified therapy. We could have slowed down the progression of disease or regression, and we haven't done that. And we see that basically on a daily basis. And that is, we believe that will be the paradigm change on how potentially we can change the course of disease with early detection and better medical treatment. Another patient that had 3 coronary CT angios follow-up, a baseline, then a 24-month, and then a 48-month follow-up. We can see in the first patient was initially with a statin in the first between the baseline and the 24-month. Cholesterol level went from 234 total cholesterol to 134, and LDL went down from 143 to 82. So, if we are looking at the lipids, getting below 100 and decreasing total cholesterol, you may think that, hey, this is working. When you looked at the 24-month plaque data, actually it was increasing. Still, the plaque volume was increasing between baseline and the 24-month. And the non-calcified plaque component was increasing on that 24-month follow-up. At that point, was decided to add PSK9 inhibitor at the 24-month follow-up. And then at that time, with the 48-month, we see a decrease in total plaque volume, a decrease in non-calcified plaque, and a slightly increase in calcified plaque. So those are the treatment adjustments that with direct atherosclerosis visualization, we could potentially be making to really slow down the progression of disease and hopefully, which it needs to be validated, decrease cardiovascular morbidity and mortality. So with that, I would like to pass to our next speaker. Thank you.
All right, great. Thanks, Ricardo. That was great. Let me just make a few points here, that came up from Ricardo's talk. He talked about he and Maros talked about the different plaque types, and we always talk about it as a predictor of risk. But the question is, what is the definition of risk? When you look back at the CT literature, you can use all of these plaque characteristics to predict it's the strongest predictor of future major adverse cardiovascular events. It's also the strongest predictor of who's a rapid progressor of disease versus slow progressor of disease. It's also the strongest predictor of who's going to be a statin responder versus statin non-responder. and it's also the best predictor of who's going to be ischemic or not. Somebody had mentioned that we have a plaque-based FFR tool that's FDA cleared, so please come down to the booth. We are not going to talk about it today. I just wanted to say, like, when we talk about early detection and prevention, I'm not talking about going to screen the world right now. 80% of the people that we image don't have severe obstructive coronary disease, and ischemia is no longer the question. The question is, amongst all those people who have this quote-unquote non-obstructive disease, like, can we try to attenuate their risk of MACE, rapid progression, statin non-response, and so on? So that's what we're going to try to talk about today. I know that when we first introduced this thing, like, everybody looked at these numbers, well, what do I do with this? Like, how do I apply this into clinical care? That's the next step that we need to go to, and that's why John Osborne is going to come up and talk to us about actual cases and how he would treat. John is a board-certified cardiologist and founder of State of the Heart Cardiology in Dallas. He's got expertise in preventive cardiology, a lot of expertise in preventive cardiology, cardiovascular genetics, and advanced non-invasive imaging. He, back in 2005, I think, said, hey, I'm a solo practitioner, I'm going to buy a CT scanner for my practice. And so he's been doing this for a while. He's had over 2 decades of experiences in clinical trials, published extensively in vascular biology and atherosclerosis, fellow of the NLA, director of cardiac imaging at Carrollton Regional, and he's pursuing an MSc right now in cardiovascular management at the London School of Economics. So we're going to bring John on. John is like the most, like, boots on the ground, pragmatic, preventive cardiologist, where symptomatic or asymptomatic, it doesn't matter, we're still preventing something. So he's going to take us through some cases. So please welcome John Osborne.
Well, hello, everybody, and thank you for joining us. I want to point out that you guys chose wisely, because the other lunch program was photon counting CT, which is pretty cool, amazing pictures, but this is really the stuff that's going to make a difference in the future. So I have to represent, by the way, Texas. We have Colorado, we have Denver, and we have Miami, and Oregon, but I'll be representing Texas for today. So the how-to guide, integrating atherosclerosis, stenosis, and ischemia, and I have to say, too, 2005, incredible year. We've been celebrating this whole program, the founding of the SCCT. I know 4 of us, Mark's too young, but the 4 of us were all there in 2006 at the first inaugural meeting of the SCCT. And 2005 is also an amazing number for me, because as a preventative cardiologist, up until 2005, when we got my first 64-slice machine, I used to cath people. I gave up angiography, invasive angiography, in 1 year in 2005 because cardiac CT was so good. I could get better data, more accurate data, even doing, qualitative analysis, not the amazing quantitative analysis we have these days, but cardiac CT was so good that I gave up cathing people 20 years ago, never have been in the cath lab for the last 20 years. And it's been phenomenal. In fact, I'm going to say, not only did I give up cathing 20 years ago, but now about 4 years ago when Jim called me and said, let me tell you what I've been doing. I'm doing a new thing, found a new company called Cleerly. Immediately, the light bulb went off, the same light bulb that went off in 2005, that I could stop cathing people because cardiac CT was better, more accurate, safer, simpler, and gave me more data. So 2021, I like to say, I stopped doing cardiac CT, because there is no such thing as cardiac CT anymore in my practice. It's cardiac CT with Cleerly. So that is cardiac CT 2.0. So let me show you a little bit. Here's an example, 51-year young male, as I say, atypical chest pain, blood pressure reasonably controlled, BMI is 31, so he has North Texas underheightness, as I like to say, prediabetes, hypertension, dyslipidemia, lipids reasonably okay, and he's on standard drugs for blood pressure and cholesterol. We did it Cleerly on him, and what's amazing is atypical chest pain, and here he has a total plaque volume, which is one of the best predictor of events and MACE, et cetera, outlined by Jim and others on the panel. Total plaque volume that puts him in stage 3 atherosclerosis, above 750 cubic millimeters. Most all that plaque is all non-calcified plaque. Only a small fraction of that is actually calcified plaque. the vast majority would be invisible. If this guy had a calcium score, he'd probably have, and I hate the term, a low calcium score. But you can see here we have a much better appreciation of what's going on. But again, it'll be even better because we can really look exactly at what we're seeing here. And here you can see there's mild stenosis, mild narrowing, nothing obstructive. Importantly, too, the value of cardiac CT, I like to say, is we're excluding surgical disease, left main, three vessel disease. They go to surgery. Everybody else gets excellent medical therapy and treatment for angina as accordingly. But here we give an incredible view of what's happening in that vessel, the extensive lipid-rich plaque, the worrisome plaque. And then here's the spreadsheet view. What cardiac CT with Cleerly does now is take what took 20 years ago, hours to look at this, analyze it. Of course, it was all qualitative. Now, in one page, we consolidate an incredible amount of data, both stenosis data on the bottom, we have no obstructive disease, but most importantly, the spreadsheet view, as I call it, looking at the total plaque volume, segregating it out to each of the individual vessels, and then, of course, breaking that down into the calcified, non-calcified, and the low-density non-calcified plaque. Very, very worrisome pattern for this guy. Nothing obstructive, but very, very concerning for subsequent downstream events, given his non-calcified and particularly his low-density non-calcified plaque. So the beautiful thing is now, before we can probably say two things. One, his chest pain is not cardiac, but he does have extensive plaque volume and worrisome phenotypes of plaque volume. In 2025, now, with incredible data, particularly in the last 10 years, I would say, with the advent of PCSK9s, SGLT2s, GLP-1s, and of course, incredible data with ezetimibe as an add-on drug as well, we have an incredible array of highly effective tools to treat plaque, to stop plaque, and if we do Cleerly show we're reversing plaque. So we have an incredible array of highly effective tools. Historically, we'd wait till you have an event, you'd survive the event, we'd lose half the people because our first event would be likely a fatal event, and then they'd go for a mechanical intervention because they were so far along in the disease process, and then we'd start treating them medically. That no longer has to be the case. Let's find the disease, treat the disease, or as I like to say with cardiac CT and Cleerly, there should be no longer might, could, maybe, possibly. There is the disease, and there's not the disease. And this is really the best way to allow us to really understand what is the disease status in a given person. Then we can then determine what other adjunctive tools, in addition to diet, exercise, and medical tools we might use. And then ultimately, and we can never do this until we add quantitative cardiac CT, is to be able to then determine, are those tools, which work well in population studies, are these tools actually working in this individual? So it is taken down to the individual level, no longer the maybe, could be population correlation-based approaches that we used for many years. This just shows that by the staging criteria that we have with cardiac CT and quantitative CT, that there is a progressive relationship between stages, stage 1, 2, and 3, means higher risk of major adverse cardiac events, shown in prospective studies as well. And if you look at total plaque volume, that is by far the greatest indicator of major adverse cardiac events, above and beyond and additive to stenosis as well. And in fact, if you look specifically at the phenotype of plaque, high-risk plaque features are much better predictors than stenosis, as you can see here, looking at the hazard ratios, or even a history of prior acute coronary syndromes. So another case here, again, you can see the details here. He's on no medications, this 48-year-old guy with palpitations, but again, extensive plaque volume. He's actually stage 2, very minimal calcific plaque, and here you can really see the phenotype, of course, lots of lipid-rich plaque, lots of reverse modeling, and then here is the spreadsheet view, the totality of the plaque, lots of that low-density non-calcified plaque. By the way, how I discuss this with my patients, the calcified plaque is the cinder cone. That is the extinct volcano. Every other plaque we're looking at, the low-density and non-calcified plaque, is the lava. That is the active plaque. that can rupture and progress, et cetera. And of course, that becomes our major therapeutic target going forward that we can now quantitatively assess over time as well. Again, no significant obstructive disease, but we found out, more importantly, we have phenotyped this guy and understood that this guy has extensive plaque at the age of 48. And certainly no medications was the wrong answer, and that we would, of course, consider now we understand his disease in this individual person. We now can begin to initiate highly effective anti-atherosclerotic therapies as well. I hope medical therapy, statin, ezetimibe, would, I think, hopefully be a good start. We could look deeper into his lipids. Interventional therapy, hopefully, this is someone I would never cath. In fact, it is very, very rare now when I come across anybody that needs an intervention at all, because unless they have surgical disease, and if they do, that's a very small number of people, they get surgery. Otherwise, it's medical therapy for everybody. And then lastly, the ability of quantitative AI with Cleerly outpaces both at near term at 2 years, at 5 years, and even extended out to 10 years, clearly better stratifies and understands a risk of MACE better than clinical parameters, CAC score, stenosis, even using Cleerly, but is the Cleerly atherosclerotic quantitative CT that really underscores and gives us the best insight into the future, the ghost of Christmas future, into what can happen or could happen in the ghost of Christmas future. Our goal as preventative cardiologist is to help ensure that does not happen with the appropriate guided anti-atherosclerotic tools. And then lastly, more data showing, even comparing Cleerly ischemia, which we're not talking about today, with 15 oxygen PET scanning, that this approach really is a superior approach using percent atheroma volume to determine subsequent risk. With that, I will turn things over to our last speaker, Marc Bonaca.
Great. Thanks so much, John. And so I'd like to introduce our next speaker. Just a couple of points before I do, just based on what John was saying. We had talked about how every patient is an opportunity for prevention, right? The vast majority of the patients who undergo CT will not have obstructive disease. They will not have ischemia. And so how do we treat those people? That's what the insurers allow us to do right now, right? But, if we ask ourselves where the greatest unmet need, upwards of 60% of people who will die at home or suffer a heart attack will do so without any subsequent symptoms. And so I had the pleasure of meeting our next speaker through a trial that was being led by our Chief Medical Officer, Udo Hoffman, and the principal investigators are Deepak Bhatt at Mount Sinai and David Marin at Stanford University. And through that, they called together just sort of this think tank of clinical trialists in cardiovascular medicine to try to address that unmet need, right? They said, if the vast majority of people who are going to have heart attacks or die of sudden coronary death do not have any symptoms before their event, then we need to demonstrate whether or not we can improve that identification, improve patient health outcomes. And so hatched was a trial called the TRANSFORM trial. The TRANSFORM trial is a 7,500 patient randomized control trial. We're about 4,500 patients enrolled, I think, into the trial. It's event-driven to determine whether we should be using CCTA imaging and AI plaque analysis to really guide therapy in a manner that improves patient health outcomes. Who's leading the contract research organization or the academic research organization is Marc Bonaca. So he will come up to us and tell us all of the things that he's learned about sort of how we're going to approach coronary artery disease in the last few years, and then share with you some case-based approaches to actual treatment. And then the last thing that I'll say is what we hear a lot is people saying, well, I put them on a statin. What else can I do? There's at least a dozen classes of medications that we can use for prevention. So we need to start using those medications judiciously and effectively to track risk and also residual risk after somebody gets treated, but that particular medicine isn't working for them. And Marc's going to speak to that. So Marc Bonaca.
Thank you. It's an honor to be part of this amazing panel with all of you here. When I trained in cardiology, we were left guessing who had disease with risk factors, as Jim said, or stress testing to understand if somebody had a stenosis, which really was a misunderstanding of the biology. But we also only had a couple therapeutic options. It was aspirin and a statin, right? Now we have a myriad of therapies we can bring to bear if we could just understand someone's disease. And so we are at a time where we can understand a patient's biology and their plaque risk as well as their anatomy. We understand their physiology. We can put it all together to really personalize care. These are my disclosures. And the other part of this I want to make, point I want to make in the next few minutes is that we put a lot of trust in these numbers. It's easy to say stenosis, percent, FFR, all these things, but really it's a patient in front of you. And the data behind the images and the numbers that we're looking at and the trials that prove what we're doing matters is a differentiator for me. When I don't want to just see a number on a screen. I want to know that there's a robust set of data supporting what I'm doing. So I'm going to show you a couple of data points here. This is a slide that looks at sort of the old school Diamond Forrester pretest probability and the area under the curve for MACE. This is how likely my patient in front of me is going to die of a heart attack or stroke, and particularly a heart attack. And then you can look at stenosis. There's sort of a marginal improvement in that area under the curve. But when you add atherosclerosis or plaque, then you have a significant improvement. In fact, we talk a lot about calcium. Everyone's afraid of calcium. I get multiple referrals in my clinic for people whose calcium scores go up after starting a statin who are panicked. But calcium actually is not prognostic at all for future MACE if you correct for non-calcified plaque. So calcium is not the issue. It's a complete misunderstanding of the disease. Now, one of the key issues I run into is lack of specificity with CT. It's really troubling to a patient when they go to the cath lab for they're scared they've got a significant lesion. It's not really there. It's also a waste of resources for the cath lab. And so when you look at different ways of measuring stenosis, ischemia, and other things, the actual data to support the accuracy is critical to me. And so you can see here a couple of different ways, comparison to a gold standard of invasive FFR. And I think the message here is they're not all the same. Know the data for the product that you're using, and know that when you have an indication of something that's important, you're sending someone to the cath lab, you want to know that it's real. And here are the two different data sets, small, but looking at different modalities. And you can see there's a wide range of performance for AUC and specificity. So how does this guide us? Well, plaque volume is really important for future prognostication. We know that plaque is predictive of risk, may actually inform how we practice. The curves you're seeing on the left are curves for outcomes based on whether someone got medical therapy alone or revascularization. And you can see, I'm sure even in the back of the room, the curves cross. And so there are levels of plaque or atheroma volume that may tell us when we should revascularize. Here they cross at 13. I understand that the confidence intervals don't cross anymore at 18. But this allows us to personalize then the pharmacoinvasive approach of when do we go to intervention, how do we couple that with medical therapy. And of course, when we talk about lipid lowering, the next year we'll see more lipid lowering therapies, oral PCSK9, CETP inhibitors. Who's going to get the benefit? Who are you going to fight with the insurance company to get coverage? Is it the group on the left who have no plaque? Or is it the group on the right who have a lot of plaque and are going to get a big benefit? How do you pick right now? Because the LDL actually is a poor surrogate for this. But plaque can tell you where you should focus your attention. You can see on the right side that the more atheroma you have, the more you're going to respond to intensive therapy. So we are at a place where with these two icebergs of imaging-based analysis of patient risk and physiology, these were distinct areas where we had to do a lot of different tests, and you can see the mini thumbnails up there, but in the interest of time, I'm not going to go through all of them. We're at a point where we can bring this all together into a single test and do a holistic assessment of imaging, biology, and physiology, and here's a picture of it. I mean, this is a nice picture, unfortunate patient, because you can see they have disease here. Now we have a lesion-based analysis of each of the 4 lesions that we're looking at. And here in the RCA, we have a lesion. We can tell that there's a diameter stenosis of 76%. Ischemia is likely. We also know the length, we know the morphology of the lesion, and we even have physiology, and we have it for each and every one. And in the interest of time, I'm not going to read every number here, but this is an incredibly powerful tool to sit down with a patient and walk through every single lesion, not only, but if I'm going to send them to the cath lab, I can tell them what's going to happen there. Here's another patient. I'm just going to show you briefly. This patient's got a big problem, right? They've got a problem in the LAD, but whether that involves the left main or not is a discussion I have to have with my patient about whether they need to think about bypass surgery or is something we can do with PCI. I'd like to have that conversation in the office with them, not on the cath lab table. And now we can really start to think about how we're going to tackle their disease, or maybe how we're going to be intensive with their medical management. So this is a complete tool for me as a preventive cardiologist for informing my patients and making those decisions. So here we have the best of all worlds. We can pinpoint lesions. I'm not an interventionalist, but my interventional colleagues can pick their size and length and landing zones, their location. This is all of the information my interventional colleagues know. I know how vulnerable their plaques are and how intensive to be with their medical therapy. And we can really plan a holistic pharmacoinvasive approach to treat their biology. And here you can see it's FFR, QCA, IVUS, OCT, and NIRS all in one package. All right. Well, I know we're short on time, and I just want to touch on clinical trials. So I'm a clinical trialist. I'm evidence-based. I want to see the data. Numbers are neat, pictures are neat, but data rule the day. And I do think that we are at a place where we're having a tremendous amount of data supporting CT. Here are 3 data sets, Confirm 2, Paramount, and Transform, all poised, I think, to transform the way we practice cardiovascular medicine. This is a busy table. I'm not going to read it all to you, but you can see the scale of clinical research that's ongoing to support this practice, whether it's large registries with over 13,000 patients, multiple data sets, different countries, different populations, and a prospective randomized clinical trial with over 7,000 patients powered for outcomes to demonstrate that what we've heard about from this panel is the way we should be practicing medicine. And I know there's some in the audience that are already doing this. I see Dr. Boone over there, but we need to generate evidence to change practice broadly. So this is the Paramount study. This is in symptomatic patients, 500 who have symptoms of disease. They get their baseline assessment, and they get usual care, which is generally stress testing, may lead to cath, stenting, other things, versus a personalized plaque-based care approach. And there's a 180-day assessment looking at composite of diagnostic certainty, risk factor status, and the appropriateness of intervention, PCI. There's also broader endpoints looking at hospitalizations and adverse events. Is this a better way to understand the biology and anatomy of a symptomatic patient and guide their therapy than guessing and getting a stress test? Transform is really broadening this. As you heard, 60% of people who die of a heart attack won't even have the benefit of knowing they had the disease first or having an opportunity to take a drug to prevent that heart attack. So what if we did what Jim said at the beginning, like we do for mammography and colonoscopy, but we imaged people to detect disease and we treated them up front with all of the great drugs we have staged to the degree of disease that they have. So this is an outcomes trial. There's also serial CTs, so we'll understand how plaque change relates to outcome benefit, and we hope that this changes the paradigm of cardiovascular prevention. So here's an executive summary and just some questions, and I don't know, Jim, if you want to take these to close us out, and then maybe we have a few minutes for people to ask questions.
Awesome. Thanks so much, Mark. So, I mean, these guys threw a lot at you. So, I just want to try to sum it up as much as I can in a very simple way. But, I mean, I think that what we're trying to go from is away from the surrogates of disease or sequela of disease and to actually measure heart disease itself, right, which is atherosclerosis. I think that we've got a tool now that's very safe and non-invasive to both diagnose as well as exclude disease, but more importantly, to characterize the type of disease. I think that we've moved beyond sort of the binary dichotomization of do you have disease or not, but let's figure out what is the stage of the disease, but also the classification of that disease as well. You know, we know that atherosclerosis is the strongest predictive prognostic marker for bad things, right? MACE events, rapid progression, medication non-response, and ischemia. You saw a little bit of what Marc presented on sort of our plaque-based ischemia. If you look, we're the only ones right now that incorporate plaque into the diagnosis of ischemia. That's why every trial that we've done, there's at least 4 trials out there that have demonstrated that that approach is superior to the other approaches that are out there. And I think that what we can now do with this compare product is to quantitatively track disease and see whether or not you're one of these people where the therapies are working or one of these people who are at residual risk, right? So if you treat somebody with a statin, you get a 15% relative risk reduction. That means 85% of the people you've lowered cholesterol and they're not benefiting from your therapy. You don't know who they are. So I do believe that there will be a future where we track plaque. I think that that will be assessed in the TRANSFORM trial. But that sort of sums it up to me where we can use the actual disease to personalize medicine, provide precision heart care in a manner that it can actually improve patient health outcomes. So let me just ask, like in the remaining few minutes, whether or not there are any questions from the audience or for our distinguished speakers. And there's a microphone there if you guys do have any. And if not, like let's have a discussion about this, because I think that this is a new paradigm, right? And so like what we're starting to do is get beyond pixels into patient care, and you know that decision making is complex. And so we will be also presenting at the ESC a late-breaking clinical trial based on CONFIRM-2, a study that Udo is leading, and that will also compare our AI versus CCTA alone. There is one question, which is how does the plaque volume information of a person affect the insurance industry? Would this become a screening tool for premium calculations? John, I'm going to give that one to you.
Yeah, no, that's a great question. You know, 100 years ago, the insurance people, the underwriters, realized high blood pressure is a bad thing that predated medicine by about 50 years, right? Because they had skin in the game. It's money. So it's interesting that we have been talking with life insurance companies as using cardiac CT and Cleerly as the ultimate underwriting tool. So all I can tell you is I think there's some validity to that concept, and let's see what happens as this unrolls.
Okay, I'm going to do just some rapid. Oh, go ahead, Maros.
I would just add that it's not only cardiovascular disease. So, and I'm extending from calcium data, but if you don't have calcium, if you don't have atherosclerosis, the next 15 years, you mostly also don't have cancer. So this is, but don't tell them unless you have really a lot of stocks in insurance companies.
Okay, so let me ask some controversial questions just to go down the road. Like, I mean, Marc, you're a big lipid guy. John, you're a big lipid guy. Like, I mean, lipids fail. Like, there's 70% of people with high LDL have normal coronaries and no carotid disease. Like, how should we be using lipids? Should we be using it to figure out who to treat or how to treat?
Only use lipids after we know if they have disease, because then we know the targets. Is it an ApoB target, which it always is? Is it an Lp(a) target, right? They have elevated triglycerides, where other adjunctive tools such as icosapent may be useful. So I think all the labs are the ghost of Christmas future. It gives us a trajectory, but the ghost of Christmas past with the integration of everything that's affected their tendency to form plaque, good habits, bad habits, DNA, genetics, ancestry, is summed up in their cardiac CT and Cleerly. Then we figure out, using the labs, what is the path forward.
Okay, and then I've got a question for Marc. Like, you know, we were the CT core lab for the ischemia randomized control trial. Like, nuclear didn't predict much, echo didn't predict much, the ischemia didn't predict much. Like, so, you know, what is the target of treatment here? Like, are we going after stenosis? You showed that stenosis was important. You showed that non-calcified plaque was important. Should we even be doing calcium scoring? Does that help in any way at all?
Yeah, I mean, I think calcium is a very crude tool to determine in a broad population who may or may not have athero. It's not a treatment target. It's actually the reverse. So, you know, I think we need to look for non-calcified plaque. That's the disease, and treat that.
And then one other follow-up to that, like there's all big residual risk, right? For every drug, Ozempic, Mounjaro, there's always 20% relative risk reduction, meaning 80% of the people are failing. How do we find that residual risk person?
Well, I mean, I think that what we see in the trials where we're testing one modality of therapy is that there are orthogonal pathways of risk. You can't treat one risk pathway and assume that you're going to prevent all the heart attacks. So the issue is that we have to address all the pathways of risk, particularly in the highest risk patients, and the risks based on the biology or the presence of plaque. And so staging treatment based on the visualization of disease.
Got it. Okay. Question?
Hey, how are you? Thank you so much for your wonderful presentation. It's been amazing. I'm one of the advanced cardiac imaging fellows at Montefiore in New York. I'm a huge fan of plaque characterization and non-calcified plaque, and it's very nice how now we can see and appreciate the risk of the plaque burden, and it's important to define that. But in clinical practice, one of our biggest limitations that is unfortunately is not widely available. Not all the centers do it. And my question is, if we're talking about prevention in terms of the guidelines, in order to see the non-calcified plaque, we need to do the CCTA first. And the main indication for CCTA is chest pain. So we're a little bit delayed in terms of prevention. So on what point are we right now in order to make it as part of the preventive screening, especially because a lot of the clinicians are not always cardiologists. Some of the general cardiologists, they don't know what to do with a CADRAS nomenclature, or some others are internal medicine doctors, family medicine doctors, or nurse practitioners. So in terms of guidelines, my question is the use of, in what point are we now in order to request or order a CCTA as part of, in the guidelines as part of preventive and not just for the symptoms?
So I'm going to ask Maros to answer that. But I will offer one thing. This past week, there was a proposed national fee schedule, a proposed reimbursement for advanced plaque analysis by Medicare. As of January 1, in the hospital outpatient payment setting, it will pay at about $950. In the outpatient imaging for the Medicare physician fee schedule, it will pay at about $1,032. So, there will be a way that you will get reimbursed for this, albeit in the symptomatic patient. However, in that symptomatic patient population, 80% of them have subclinical atherosclerosis that needs to be treated. But to directly answer your question, let me pose it to Maros and see what his opinion is.
Yes, and it's very important. Yes, the decision is about patients that actually have a diagnosis of chest pain. It's going to be, and then SCCT will educate about it a little bit more. What I would say, again, for 20th anniversary, in the audience, Jim, Udo, I think what the CT field has been really the best of all imaging modality and continues to be the best is the generation of evidence. In order to reimburse plaque for asymptomatic patients, we need randomized trials, we need transform data, we need others, there's wide field. Everybody who can sort of help enroll the patients, whichever study it is, whichever trial it is, it's going to be a huge body of evidence. And in order to get us to 1A, you have to have multiple positive clinical trials. We will have that, I truly believe, in 2 or 3 years. SCCT is here to then at stage with the guidelines, with the advocacy help to let it happen. It will take a time, but it will happen.
Agree. And then just to tell you, the Paramount trial that Marc talked about, that should read out sometime next year. The Transform screening trial, it's an event-driven trial, so it's unknown until the events occur, but we're estimating H2 of 2028, we should see the results of that landmark screening trial. And I'll just end here, guys. The one last thing, we didn't talk about ischemia at all today, right? But what I can tell you is that when you look at the past literature in CT, plaque causes ischemia, and then actually calcified plaque is negatively associated with ischemia. If you don't have the plaque information, you will always be diagnostically inferior. So we created a plaque-based FFR tool. Please come down and see it. But when you look at all of the data, it always reigns superior to all the other modalities that we have. So just in closing, I say, we're committed to the evidence. Purvi, did you have a question?
I was just going to ask a quick question.
Yeah.
So you guys showed that it's the total plaque volume that matters for mortality. So one argument can be, do we have to go after all these other CT markers of high-risk plaque, other tools? Because ischemia sub-study also showed that, right, for quantification, it's the total plaque burden. What are your thoughts on that?
Okay, let's just do rapid response for anybody. I've got an answer to that one.
I think for the prognosis, it's fine. But you won't know what you're doing when you're treating the patients unless you track the change in the disease. I don't think the total plaque volume will be enough for the tracking of the success of the disease and affecting outcomes through the successful treatment of the progress of the disease.
Yeah, so, I mean, just to go on, go ahead, Ricardo.
I agree as well. Prognostic value, total plaque volume is probably one of the most important and predictors. But if there is a single lesion, you want to understand the morphology. You might want to decide, should I revascularize or not? So that's where potentially you might need more additional information. And the plaque morphology, not only plaque volume, but the plaque characteristics and morphology will be interesting to understand the vascular biology and response to treatment.
Yeah, and the one thing I can say is that the commonality between everything that we do that's good for people, excluding antithrombotics, right? So not rivaroxaban, aspirin, clopidogrel, but everything else that we've seen today, colchicine, PCSK9 inhibitors, icosapent ethyl, statins, low sodium diet, increased physical activity, they all have a common phenotypic mechanism where they slow plaque progression and they convert non-calcified to calcified plaque. So if you go by total plaque, you're not going to be able to track whether or not somebody's actually improving and responding to the therapies. I mean, this field is just starting, but I do envision a day when we stop looking at LDL cholesterols and instead start looking at actual disease. And we'll take one last question.
Madhvi Kadiala. When you're tracking plaque progression, the assumption is that you're using the same CT scanner with the same KVs and protocols, but in reality, when we translate it to clinical practices, we're getting images from various different scanners, heart rates, and clinical. How can we be? How sensitive is the tracking, and can we rely on what are the threshold changes that we could reliably say that this is true change?
Yeah, it's a really good point. Like, I mean, guys, you're going to hear AI for the next 5 years, right? But not all AI is the same, and not all plaque softwares are the same. There's some out there that have some fundamental image processing limitations, so just be careful because they're not all going to translate. In terms of like the different image acquisition protocols, different scanners, we actually looked at that and we published that. You get very consistent results, like despite like different differences in kVp, 100 versus 100 kVp and 120 kVp and so on. But we're still going to have and then the other thing is, I see George Westby. He probably has done the most rigorous study looking at sort of the beat to beat or the interscan variability. In his, if I remember correctly, 9 cubic millimeters was the. So if you get somebody with 150 and then they come back and it's 158, it's probably within the realm of noise. If you get somebody with 150 and they go to 190, that is not within the realm of noise. And then the last thing I'll say is that I think what the field needs is a harmonization technique across all vendors, right? So normalize each scanner, each scan type, each, whether it's prospective or retrospective, whether it's high MA, high kVp, photon counting versus energy integrated. Like, we're going to need to do that, and that will come. But so far, so good. All of the data shows that there's pretty small changes between those scanners and that we can use it robustly in clinical practice. So on that note, guys, I'll just thank you for your attention. Please come to our booth. We'd love to see you. And then, like, one other last thing is we have at 3:30 to 4:30, Tony DeFrance, who I think is sitting there. He was one of the founding members of FSCCT. Jim Hartman, our commercial officer. Udo Hoffman, our chief medical officer. All will be at the booth, so like come and we'd love to talk. Okay, thank you.